Thank you, sir. I would now like to invite you to moderate the first session, the plenary session, on the theme Health and Equity.
May I request Dr. Ritu Priya to come up on stage? Uh, Dr. Ritu Priya is a friend of over 30 years. Um, uh, uh, our friendship is through the Medico Friends Circle. She is a professor at the Center of Social Medicine and Community Health at the Jawaharlal Nehru University in New Delhi. She completed her MBBS at the Lady Hardinge Medical College in 1982 and then did her PhD where she is teaching now. Her interests are in health system development, the politics of knowledge production, and the relationship between different health systems and expert and lay knowledge. She works particularly on health of marginalized groups, Dalits, and urban workers in nutrition and communicable diseases. She has been an advisor to the National Rural Health Mission, and she's been actively involved in the People's Health Movement over 3 decades. A recent book that she edited is titled Dreams of a Healthy India, Democratic Healthcare in the Post-COVID Times. It is because of the breadth of her work and her advocacy for pro-people's health that we have invited her to give the inaugural talk titled Equity, Equality, and Empowerment in Healthcare. Dr. Ritu.
Good morning to everyone. I would like to begin by wanting to thank the organizers, the Department of Medicine, CMC, for giving me this opportunity and privilege of sharing my thoughts on this theme, but even more for taking this theme and bringing it here to this tertiary and teaching hospital. That is what struck me first when Anand spoke about it to me. For public health, with its mandate of improving population health, equity is an inherent part of what we are mandated to do. But when, as clinicians, the individual, and rightly so, must be the focus of what you deal with, then is it always such an evident issue to deal with or to even examine and attempt to understand? But disparities are something that are experienced by all of us. And I think you as clinicians see the consequences of those much more than we do with our numbers and figures that we tend to deal with. So I'm looking forward to 3 days of a lot of sharing and learning from the experiences that you have. The importance that I think the theme has for clinicians, and what I will attempt to do through this half an hour that I have is to share some of the data, because despite our knowing the gross disparities that we all evidence around us, reality checks are important, and it's important to see how any attempts made towards equity, how far have we gone, where have we gone, and what kind of fruits have they borne, what have been the positives and what have been the limitations. So we take some kind of a look at that, and then come to what is it that is in reference to clinicians. I see that there is, of course, the relevance that any attempts at equity which come from developing the kind of systems we do for health and healthcare are what bring to you what you have in your hands to deliver when you deal with suffering patients. And therefore, the constraints that you have on you, the kind of moral burden you have when you're not able to do what you know you should be doing are all issues that concern many of you. And I certainly know that this hospital and college is well entrenched in dealing with those kind of issues. The other, which sometimes I feel is less recognized, is the role that clinicians play in actually shaping the system. Each one seems to think that what we do as clinicians is what we do with patients. What is given to us is by the management or by the government and the kind of rules the MCI had built for us, or the kind of education system and so on. But eventually it is the specialists and the experts of the system who are leaders, who provide the content to the system. And I would think that they shape much of the way the system gets shaped, consciously or unconsciously. And therefore, the kind of understanding we need in the relationship with system shaping and the clinicians. What I'll try to do here is, like I said, is some brief data which we need to keep in mind when we talk of equity. What is it that has the situation is that we deal with against the background with which we are looking at attempting to bring health equity, and what are the challenges in the present times? Where can we go from there? How can we think about it? And certainly this is a time of flux where we have a lot of rethinking to do. And shared rethinking is what will bring us best fruits. Doesn't seem to be moving. Okay. Equity, something that we've already heard of earlier, and the very interesting logo that the student developed. One, the idea of the fence, which has been there with us for some time, and then the tree, and showing us the need for different people for different kinds of support and systems to ensure equal access. But the idea of equity as against equality comes with a lot of historical baggage. And but let's first go to what the WHO tells us about what is equity in health, and then we'll move from there. It brings in the issue of fairness and avoidable and remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality. So it's the unfairness of the system which creates that disparity, which is to be addressed. Health equity is achieved when everyone can attain their full potential for health and well-being. Now, clearly, this is like the aspirational WHO definition of health, which is not a state of being that any society is ever going to be, but we certainly need to keep our aspirational goals before us. And that's what guides us in our work. Social health and health equity are determined by conditions in which people are born, grow, live, work, play, and age, and the biological determinants. The biological, which we see as age, sex, genetic composition, and so on, are well known as medical people and in our biomedical training. The economic and social determinants may not be that obvious until we examine subgroups and data which tells us differences across groups, because individual differences can have a lot of combinations of these, and therefore difficult to decipher between the social and the biological. So just to take a look at what divergences there are internationally and how they've evolved over time. This is some maps from our world in data, which shows us, the first one is showing us an equal world in 1800, where this is against life expectancy. So the red are the lower end, 25 years, and the deep blue is 85 years, and in between the shades that you see in the key at the bottom. 1800 was an equal world, but a world with life expectancy of 25 years and around that. What you see in 1950, after 150 years of colonialism and imperialism, is Africa and the Indian subcontinent parts of Oceania, which are still in this deep red, shifted a bit to the orange, while other parts have moved dramatically. And so from something like 35 years, the Americas have moved to 68 years, Japan on the other side to 61 years, Europe to 66 years, and so on, while India is at 35. And that's therefore a time of independence somewhere around that. In 2015, there's no red left. And therefore, a movement has happened in improving life expectancy across all countries. Of course, there are disparities, there are major differences. India is at 68, Japan is at 84. And you have, of course, much below 68s as well. So what I wanted us to see here really is one, of course, the differences internationally, the clear markers of the colonizers and the colonized countries, where the first four in 1900 are Europe, the Americas, Japan, and Oceania. And they continue to be at the top even today. But what we do see is Europe sort of on a bit of a declining trend. If you see the graph lines, I haven't got them here. What we see is that from 1900 to 2019, so about 120 years, in India, we have tripled our life expectancy. Across the world, it's been a little more than double. And therefore, what this data shows us is not complete doom. It's showing us that things have moved, and things have moved because of the kind of century that we've had in the 20th century. The 20th century was a century where we celebrated equality, the idea of equality, where colonies became independent, elected governments came in, adult franchise with an equal vote for everyone, welfare states, social development policies, spread of the benefits of science and technology to the masses, and improved standards of living, including access to some kind of healthcare. Processes highlighted addressing issues of women, Dalits, the historically exploited groups, Adivasis, various sexual orientations, and so on. And these have all asserted their voices or got space to assert their voices. And therefore, life expectancy increases are a reflection of all of this. The flip side of this seems to have been that it's not been equitous. There was the imperial powers and what it meant to them, and the developments as well as the exploitation that went with it. However, subsequent post-1950s as well, the kind of state and market-led development that has happened, whether in the capitalist countries or what was the communist bloc, promoted a consumerist and ever-escalating needs culture, and thereby a commodification of health itself, dependency on medical technologies, on experts that tended to promote over-medicalization, systems that tended to do that, the medical industrial complex that promotes that most actively, and so on, have been part of the flip side. To some extent, as the logical culmination of that kind of development, we have the 21st century, which sees crises, the environmental crisis, which it's us all in the face, and in Delhi, we are facing it, we are breathing it all the time. And the need for mitigation of those crises. These crises like is the environmental crisis, but it's also about the huge disparities in economic terms, the kind of backlash to the politics of equality that happened in the 20th century. And therefore, the kind of escalating inequalities, shifts in policy, which are escalating inequalities very dramatically. And we saw in COVID times how they further pushed the inequalities up higher than ever before. And these are all civilizational crises. These are not for a country or a region or a small part of the world. Instead of building on the social and health gains of the 20th century, we seem to be sort of going beyond the optimal limits of the 20th century imagination. And therefore is the time for us to reimagine. rethink how we don't lose the benefits of the 20th century, but build on them to remove the negatives, that consequences, and deal with the crises that we are faced with, come up positively for them, and therefore revisioning of development models. Central to the removal of health disparities through equity, therefore, is, just summarize that, is about the fair distribution of material resources and access to basic goods and services, including healthcare, as per one's need. It's also about social discrimination that contributes to the unfair access to services and resources. A third element that's argued for by some scholars like Wilkinson and Marmot, but others contest it as distractions, is the requirement of social capital, social cohesion, cultural capital, knowledge, and ways of doing and practicing by the large number of lay people and communities that ensures biopsychosocial integrity. And it's not just then about material goods and services. The disparity that some people see in their own lives, even though they don't live in destitution or abject poverty. They have the basic material goods, but they are seeing the inequality that they experience because of the huge disparities. And thereby, aspirational needs, frustration of fulfilling aspirational needs, the stresses that come from that, and therefore the kind of lack of confidence, self-esteem, all are sort of related to this relative poverty, and thereby consequences of that for health behaviors as well as for health per se, biologically. Therefore, how do we look at this biopsychosocial dimensions as well seem to be important when we try to decipher and diagnose the causes of inequality and what do we do with them. Now, just for the data part, what I've done is looked at incomes, health expenditures, and outcomes in terms of life expectancy. Now, in India, the disparities of economic assets and wealth is calculated by Chancel and Piketty in 2017. Again, something which some economists may fight about, but it seems to be well taken largely. In 2015, India's top 1% held 42.5% of the wealth. The next 9% holds 30%. And all in this room are certainly part of this top 10%. Actually, the top 3%, but, and Ravi is here who can correct me on this, but the data that I have here is telling us about 10% at the top, who have 74% of the wealth. The middle 40% now hold 23%. So they're already below their entitlement in population terms, so to say. And the bottom 50% is the stark one, hold only 2.8%. Half the population holding only 2.8% of the wealth of this country. The top 9 billionaires, and this is before COVID, is equivalent to the bottom 50%. Their total wealth of 9 persons is equivalent to 50% of their bottom. So this is the context, the economic context in which we are talking of health equity. Therefore, what is it that we are aspiring towards, and the challenge of it, I think, is huge, and this sort of starkly puts it there. Just to see the trajectory of what has happened. This is again from Chancel and Piketty, bottom 50% of national income share, how have they fared from 1950 to 2010 as a share of the national wealth? In 1950, the bottom 50% had a little more than 20%. And now, they moved up a bit till the 80s, marginally, but moving up to something like 24. And then it stagnated, and then dramatic decline after 1990 that we can see here. And so they're down to, if this is 2010, you go down to 19, it becomes that 2.8%. This is looking at the top 10% who actually went down till the 80s, stagnated, and then shot up their hold on the wealth, and they've now moved up. The middle 40, which could be the, the lower middle class, we see it, again, saw a brief increase, but then a dramatic decline. So what we're really seeing is the top 10% and 90% kind of divide, and abject for the bottom 50%. This is the top 0.01%, where the 9 billionaires would lie. And surprisingly, you actually see a decline from the 50s to the 80s, and then the sharp rise. So there's something in policies which makes things different. Systems work differently with different ideals and values and principles that underlie our policies. And this was sort of stark marker to me of that. So I thought I'd just share this. It also therefore gives hope that if we can get our policies right, then there is possibility of not maybe the complete equity that we saw in the definition of WHO, but certainly moving in that direction. The health consequences of some of the socioeconomic differences are seen in this paper from Kumari and Mohanty 2020 in BMJ, where they've used NFHS data to look at the differences of age-specific death rates across regions, religions, and caste. And what this one shows you is across regions, South being with the lowest death rate by a margin, and then the others moving up, the North, the East having the poorest and the highest death rates at the top, and the rest in between. This is caste groups, and sort of expectedly shows you the difference between SC, OBC, general. The ST being better in death rates than the SC and OBC is something which, some people may want to question, but broadly that there is this difference between the general and the others, and you see the expected kind of gradient. Among religions, again, the Christian group stands out very clearly, and the others, the Hindu and Muslim, are very close together at the top with the highest death rates. So with these kind of group data showing us the implications of social structure for and the position in society leading to health inequalities, if we now come to how do we see health expenditures, access to healthcare, and thereby the implications, because that's what we are all really going to be engaging with. With that, the backdrop of that differences. Healthcare access and population health outcomes in terms of are evidently related, but they are very nuanced. It's not a linear relationship. And what we do see is the differences by the groups that we see, and the US Institutes of Medicine saying that in their estimation and the studies they have done, in the US, the increase in life expectancy, 90% of it has been because of other development, and only 10% has come from healthcare. So while we keep that in mind, healthcare still remains, despite being only 10% contributor, to dealing with suffering of people. It may not mean life expectancy change, may not mean survival, but still improving quality of life. It certainly remains a very important input, and something that without which people would feel their quality of life is very much deteriorated. And therefore, we need to keep these two dimensions of healthcare clearly in mind. Now, this you may not be able to read the country figures, but what it's showing you is life expectancy and inequalities and healthcare expenditure. What we see, just very broadly give you a quick version, the United States at this end, where more than $10,000 international dollars, that's purchasing power parity dollars, as the highest, and also having fairly low differences in life expectancy across populations. But all of Europe is right clustered here at the bottom, where the life expectancy inequalities are lowest. What you see here is African countries and highest differences in life expectancy and the disparities in life expectancy being highest. Interestingly, across, if you look horizontally, China spending $1,000 per purchasing power parity, United States spending $10,000, the differences in inequality are similar. of life expectancy. So does it need that level of expenditure is a question one could ask. So there's both the vertical and the horizontal we're looking at. India is here and China is at the base here. The differences in expenditure are very clear and the outcomes as well. What we have here is, to understand some of that, we looked at 13 countries to examine this question of expenditures and outcomes and what it actually means in real terms, especially when we are talking of universal health coverage and attempting to bring a similar kind of health care to everyone at secondary and tertiary levels through financing mechanisms. That's what UHC is basically about, right? So what we see here are 4 categories by GDP. The first, which is these 5 big ones, the Japan, UK, Canada, USA, Norway. By GDP, then you have the upper middle income group, Thailand, China, Brazil, and then the lower middle income countries, Cuba, Sri Lanka, India, Ghana, and low income, Rwanda. Just look at this, the blues are showing you the overall GDP of the country, and therefore the categories that we made. The orange here is showing you the absolute expenditure. It's not percent GDP on anything, it's the absolute figure per capita in purchasing power parity. So completely comparable data, where you can see that it's a very close relationship with the blue line. It keeps decreasing as you go down, except for Cuba, which is the outlier, where you have low GDP, but a much higher level of expenditure on health. And the third bit of data, which is current health expenditure, public and private, where US stands out as having much more than any of the others, half of it being public and half being private. But half, even in the US, is public expenditure. What this translates into in percent GDP and percent of general government expenditure is these 2 lines. The green ones showing you the percentage of percent GDP of the country, and the blue one showing you as percentage of the total government expenditure. Now, notable here is Japan spends 24% of its government expenditure on health. The US spends 22%. The one we say is all privatized and doesn't do public care is spending 22% of its government expenditure. So what is happening there? We saw earlier that it wasn't getting as much as China was able to get out of what it's doing. So that remains. So this GDP business tends to obscure the absolute money that you need. You don't need percentage. What are feasibles? Because what I have as my income, it's a percentage of that I'm talking about. But what you actually need for universalizing healthcare is the absolute figures. And therefore, instead of this, the previous ones that we saw give us more real picture of what is happening. The outcomes of this, if we want to see them as correlated, is in terms of the service coverage index, which is the dark blue, and the light blue, which is life expectancy. Now, what you see here is that in some countries like Thailand, life expectancy 79 with much, much lower expenditures is the same as the US, which is 79. It is similar to Cuba. It is similar to China and marginally lower than the UK with its NHS, only 2 years lower than that. So it's raising questions about the nature of healthcare itself, and does it translate into better outcomes than other inputs as well, and where does it figure in that? India, with the differences it has with the upper middle income countries like Thailand and China, whose GDPs are 3 times the Indian. And then we have this kind of low inputs at policy level, which make this difference. But beyond that, beyond the GDP and what is happening, why are even these high income countries today feeling that medical care is becoming unaffordable, even for the US and others? It seems clearly the over-medicalization, the kind of political economy of healthcare, if I may call it that, where the doctor-hospital-centered model is so expensive, the kind of public money subsidy that went to the health sector in the 20th century in some way seemed to provide a fillip to development of technologies, to provisioning of more and more technology, which has certainly benefited large parts of humankind, but has also brought an over-dependence on technology and the push of that with the medical industrial complex, etc., that we spoke of, the iatrogenesis that it brings with it. And Illich talks about not only physical iatrogenesis, which we all as doctors may see, but also the social and cultural iatrogenesis. The dependency creation, the loss of the cultural ways of handling ill health and death. Discrimination and exclusion that occurs when things are very expensive, then you exclude many more. And that's, again, something that we see. Fragmentation of interventions, for example, in the Indian context, where we're saying primary care, the government will provide, and the secondary and tertiary can go to the private sector because the government is not footing the bill. So that fragmentation and so on. Commercialization that comes with it creates a distrust, and thereby the whole situation that we are in today of a healthcare crisis, which is unaffordable care with iatrogenesis, fragmentation, and so on, and an environmental degradation. The pharmaceutical industry is one of the biggest polluters of the environment, and that's because it feeds our care and what we do. So we need to take that into account. The two countries that we saw from that previous analysis is really Thailand and Cuba, which have optimal kind of systems where with the inputs, they give you good outputs. And some lessons that one can draw from that is strengthening of primary and secondary level services, making tertiary care as low cost as possible with optimal quality, functionality linked to primary and secondary levels, all services provided, or large part of services provided by public expenditure, examining plural knowledge systems. Both countries do that and bring it in not only into schools, but into the healthcare system, the plural knowledge systems, and decentralized healthcare management systems, which allow local context to build the local system. Now, why is this of relevance to clinical practice? As I said, I see two things. One, to recognize that the influence of the biomedical understanding and its clinical practice shapes the thinking of policymakers and planners of the system. The content of health services is something that our plans really don't question or take into account. Health technology assessment has now, in the last 2 decades, become a big area in the high-income countries because they are looking at affordability today. We are still not looking at content. We take the fashions of the day as they come from WHO and other international, more and more from other international bodies today. The expert groups that are creating this content and the guidelines for us are often now aligned with the medical industry, or over the years, our education and the research that is done, the funding and the kind of peer-reviewed journal articles that come are all feeding a certain kind of medical approach with the risk approach and so on. And therefore, all opinions dissenting from dominant views tend to get suppressed or get lesser space, much lesser space in an unscientific mode of functioning of the system. And this is a politics of knowledge, which is part of the political economy, but also distinct from it because it comes with a scientific fervor, and many of us are part of it, contribute to it, whether coming from commercial or non-commercial backgrounds with complete public interest and attempting to be rational and scientific in our approach. So what are the kind of clinical dilemmas that come with this, especially, and I'm taking only one dimension of the many clinical dilemmas that are faced in practice of practicing evidence-based medicine in resource-constrained settings. This is something all of you would be much more familiar with in everyday practice terms yourself, where you have to do triage in some kind of way to decide which patient gets more attention, who gets less, or if I attend to each one equally as an ethical, equitous practitioner, then how much time do I keep spending in my OPD and in the board and so on, that just keeps growing more and more endlessly, the working hours that I have to do. So how do I balance this? Cutting out tests because I don't have them available or they are unaffordable, and yet doing evidence-based medicine without the kind of results that I need from tests, balancing side effects and benefits, balancing safety, efficacy issues, over-prescribing to cover areas which are out of our ken because of the absence of tests, lack of follow-up, or because the patient will not come back, and so on. And I'm hoping one will learn much more about how you deal with these kind of situations in the coming days. But what one also sees, therefore, evidence-based medicine is one, and there's been some critique of it. There are a lot of people using it, and it has its benefits in terms of giving us a benchmark of what is available. But there is the practice-based evidence that then actually provides the answers. And that is where we do it implicitly or consciously. But do we not need to build a system of that so that each clinician is not left with doing practice-based evidence on their own? How do we do that? And I'm sure you've worked out some of your ways, and I'd be very interested to understand exactly how practice-based evidence and evidence-based medicine can come together to provide us contextual solutions and answers. I won't go into this. I think I'm already, just tell me, Anand, about time. Yeah. These are examples from a blood banking study where she attempted to look at the rationality against WHO guidelines of prescribers of blood. And you could see that what was called irrational was actually about 50% of those that were rational by patient benefit based on the contextual constraints, and only 25% which were clearly irrational by guidelines. So this adapting and how do we do this needs to come in. The third kind of approach are participatory approaches, going beyond the evidence-based, we're building on evidence-based medicine, but using participatory approaches to deal with the dilemmas. The discourse on quality of health services, for example, a review of that by a colleague shows that they do not, majority of them consider clinical rationality or ethics of practice. Well, when people are looking at what they think are quality, their first is the doctor interested in my interest or has commercial interests? That's about the first thing that comes to mind today. Is knowledgeable, listens to them with respect. And these are not part of accreditation systems and so on. So how do we look at these? The NHS today is very actively promoting self-care and has come to the conclusion that's one of the important things for universalizing access and for optimal outcomes. Through the HIV/AIDS program, we've seen participatory approaches with many marginalized groups, and those again give us methodologies and indicators for approaches, biopsychosocial approaches, and so on. The question that this raises, also granting diverse epistemologies. The patients will have their own way of looking at ill health, and then different from yours. They may be subscribing to different kinds of knowledge systems. So how does the ethical doctor balance this epistemological diversity with one's own responsibility as the expert to whom the patient has come due to the knowledge I have, which I was trained in, especially if it violates my own epistemological moorings? How do I then handle that? And I think that's a very live question today with the practice of pluralism becoming more and more part of our formal systems. Dr. Abimbola suggests, is that 2 minutes or 5 minutes? 5, okay, that'll do. Suggests a term called dignity-based practice. That's keeping dignity of the patient at the center. Dr. Rakhal Gaitonde's work shows how safe deliveries, defining of criteria for safe deliveries by poor Dalit women in an urban setting was very different from the RCH program's criteria of safe deliveries. My own research with migrant Dalit construction workers and their conceptions of what modern development has meant to them and what healthcare means to them felt that izzat and azadi, dignity and freedom, were the two benefits they got in the 50 years post-independence, in terms of what they were allowed to consume and, of course, getting out of abject untouchability and its practice. But they also felt that while they had improved social well-being, health had deteriorated. And health, according to them, had deteriorated because of the much longer hours of work they did as informal sector workers, the much heavier work they had to do, as against agricultural labor, which was sporadic and seasonal and so on. And one actually visibly saw the deterioration in diets from the traditional diets. And visibly, this was obvious by a decline in height over generations in their families. So there was an objectivity to what they were perceiving as the decline in health. They considered equality as the ethics of the times. And therefore, to me, I see that as an indication of what was done in the 20th century. But they also saw commercialization of all dimensions of life as the unethical dimension of the times. And this included not only healthcare and education and so on, but also just within their own community, the social cohesion breaking up because of inequalities of migrants and others, breaking up of families and social support and so on. Abimbola, I'd just like to read this because I think this puts it very, very well. We are all entitled to dignity because we possess certain ethically important features. One of those human features is that we are knowers. And all human beings are knowers. We know things, we learn, we make sense of what we know. We interpret our realities and the systems within which we have our being. If this feature is not respected, if what the Dalit construction worker thinks of health is not given due consideration, one's dignity is violated. I'm expected to do community participation, but my understanding of health and of my circumstances is not to be given legitimacy or credibility. Then there's a loss of dignity. There is a kind of knowledge practice we may call dignity-based practice. This is a 2023 article of his. Towards equity in health in the 21st. Therefore, what are the pointers that we have today to take us forward? Since this is the century of crisis and mitigation of crises, with the path dependency of the consumerist path and the kind of development that we've seen, there are also tendencies which are coming up, the SDGs, UHC, etc., are expressions of that at the level of the aspiration to mitigate these kind of challenges. But they are double-edged because they could go in either direction. They could either be a continuation of the same kind of technocentric and techno-managerial kind of approaches to development, only escalating them further now with AIs and what have you. On the other hand, we have the triggering of processes of transformation towards people-centered socio-cultural approaches with reviving the spirit of Alma Ata, but to add the learnings of these 40 years, the limitations that there may be in that vision as well, and making the future with that. The two possibilities we say are inherent. There's now the Astana conference documents and WHO UNICEF documents saying PHC is essential for UHC. So it's a UHC with PHC. PHC adds to the UHC concept. I'm proposing a variation of that, which is saying PHC principles may be extended to secondary and tertiary levels. And that then makes it a non-fragmented, but principles which are then a challenge to be applied at the secondary and tertiary level. That is where possible systems which can be equitous and to an extent affordable may be there. This is from a paper. I'm not going to read this at all. This is just to show you a paper that we did for the G20 think tank 20 approach, saying universalizing the health care or the health crisis. Because if we want to universalize the same kind of system, then it's only going to compound the crisis. It's only when we rethink the design of the system that we can actually try to move towards you. So it's PHC with UHC, and we've talked of the two possible paths in this blue and green boxes. So it's up on the web and available for anybody who wants to look at it. So just to summarize my arguments. The definition of equity, I think we're all clear with about fairness and so on. And it is the most basic and necessary for improving population health because basic material goods and services must reach everyone. But the practice of equity is not possible without a sense of equality and solidarity. Just having it on paper or as a design, it doesn't happen. It happens when all of us are thinking about it and moving in that direction. And that's where the idea of equality which is not the mechanical equality that Kwachi and others talk about as only numbers. What it was talked about in the 20th century was not just looking at difference between male and female and so on. It was about dignity. It was about equality of opportunity. It was equality of perspectives and diversity of perspectives being respected. That sense of equality has to be there if equity is to happen. The practice of equality encompasses equity, but goes further to acknowledge dignity of all and allow rationality and agency of patients and communities. Therefore, the further step for clinical practice from equity and designing our systems accordingly to equality, to, I would suggest, empowerment, where how do we add the kind of knowledge we have and the knowledge they have to empower them to do much of what can be done on their own, and therefore give the sense of dignity even a stronger base. Thereby, the need to design health systems accordingly, political economy of politics of knowledge need to be understood and addressed. And I'd end by saying that we here, all of us, are producers and practitioners of knowledge. The knowledge space is where we all work in. And therefore, that's where our responsibility really lies, in the politics of knowledge. What kind of knowledge will we generate through our research? What kind of knowledge will we practice in clinical settings? What will we transmit and how will we transmit to the next generations? And what systems models will we advocate for with the kind of science we talk to policymakers and decision makers? This is the onus on all of us, as I see it. Therefore, educating ourselves and orienting ourselves to equality and empowerment, as much as to be able to do equity, is where the social sciences, humanities, interdisciplinary public health moves us in those directions, helps us think and raises questions for us. I think there are more questions before all of us today on how to operationalize this than getting it there. But thinking about it, the shifts in mindset that are required is what I think we as knowledge space people need to really work on. And I'd look to these 3 days to taking us in that direction. Thank you.
I would like to request Dr. Anand to present the memoir to Dr. Ritu. The memoir for the speakers is a hand-embroidered bag with a conference logo, which has been made by Porgai artisans from the Tribal Health Initiative, Sitlingi. Porgai is Lambadi Women's Embroidery Collective. Porgai means
plenary. We'll move on to the other next session.